So hemolytic disease occurs when maternal antibodies are present naturally or form in response to an antigen from the fetal blood crossing the placenta and entering maternal circulation. Maternal antibodies of immunoglobulins, specifically IgG, cross the placenta, causing hemolysis of fetal red blood cells, causing hyperbilirubinemia, jaundice, and anemia. Okay, so with our hemolytic disease, what we're trying to do is prevent and treat with RhoGAM. Okay, so again, refer to 227 stuff in your readings to look all about Rh factor, but let's review the antibody screening. Okay, so in other words, how do we know mom has formed antibodies and become sensitized to our baby? Okay, well, remember we can draw an indirect Coombs test. This is going to tell us whether the Rh negative mom is sensitized to that antigen. If she's not sensitized, the second antibody screen test is performed at 28 weeks. Okay. If she's sensitized, a maternal antibody titer is obtained. So for your titer, 1 to 16 or greater is going to indicate the fetal risk. Okay. Any women with the elevated antibody titer should be considered sensitized, and we're going to closely manage their pregnancy. All right, here's your RhoGAM once again. Hey, remember it's given to Rh negative mom. Let's see. Okay. Okay, y'all can read that. Then here it is again in chart form. So what are we trying to do? We're suppressing the immune response in non-sensitized women with Rh negative blood who receive Rh positive blood cells because of fetal-maternal hemorrhage, transfusion, or accident. So in other words, the Rh positive blood goes into mom's Rh negative blood. Okay. Things to look for, here are your side effects if it's given by injection. Okay, it can be given IM or IV. Okay, and also remember that RhoGAM is a blood product, so you follow facility policy, but more often than not, policy is going to be that 2 licensed RNs have to verify and sign off the medication. All right, so for antepartum management, so when do we give this Rh immune globulin or RhoGAM? All right, well, remember we've got our screening test done at 28 weeks, and she has a negative antibody screen. So nothing's leaked over. We're trying to prevent. Okay. In situations where the woman's Rh negative and not sensitized, and the father is Rh positive or we don't know his Rh. Okay. We're going to give it pretty much after any procedure if mom is Rh negative. So that includes after abortion and miscarriage, ectopic pregnancy, a high datiform mole, CVS, amniocentesis, placenta previa, percutaneous umbilical blood sampling, blunt abdominal trauma, external version, suspected abruption, and stillbirth. Then postpartum, we're going to give it within 72 hours after the baby's born if my Rh negative mom with no antibody titer gave birth to an Rh positive fetus. Okay, so the lab test, remember on mom, it's an indirect Coombs that we're looking at to look for those antibodies. And on baby, it's a direct Coombs test. Okay, now Rh immune globulin is only for the mom. So we don't give it to the newborn or the father or any woman that has previously been sensitized. Okay, they will not get it postpartum in that case. Nursing antepartum care. So we need to provide education. We need to talk to her about the condition, what it is, to make sure that she gets it after procedures or other things that occur, such as abortion or ectopics. The purpose of the medicine, what sensitized and not sensitized means, all of those things. And of course, always some emotional support. Intrapartum care, Rh negative women who have not been sensitized. We're going to ensure assessment of the woman's blood for antibodies. So again, the indirect Coombs. And we're also going to make sure that the blood is cross-matched, looking for the immune globulin. Postpartum wise, your nurse is responsible for administering the Rh immune globulin if mom has a positive baby. If they're both negative, it doesn't matter. But if this baby is positive, we'll give it. And again, it could be IM, but if they still have their IV after delivery, we prefer to do that. Okay, so progressing on from your Rh factor and incompatibility there, we now have ABO incompatibility. This means that mom is type O and the baby is type A or B. Okay? We may still see maternal antibodies present in a serum blood level. There's going to be hemolysis of fetal red blood cells because it crosses the placenta into mom. Severe anemia, however, doesn't generally occur with ABO incompatibility, but we are likely to see hyperbilirubinemia. Okay? Now here's the thing. In ABO, the first infant can and is often the one involved. Remember in your RH, the normal RH incompatibility, what really matters, the first baby may be fine, they're not often affected, but it's the subsequent babies, which is why we give RhoGAM postpartum in that case. Okay? With ABO, there's no relationship from one pregnancy to the next. Okay? Because remember, your babies can have all different blood types. And there is no antepartum treatment. Fetal risks include anemia, congestive heart failure, erythroblastosis fetalis, hydrops fetalis, icterus gravis, and kernicterus. All right, so let's look at those. Icterus gravis and erythroblastosis fetalis. So when we have a severe Rh incompatibility, we'll see marked fetal hemolytic anemia because those fetal erythrocytes are destroyed by the maternal Rh positive antibodies. The placenta usually clears the bilirubin resulting from the RBC breakdown, but here the fetal bilirubin levels increase. So the result is jaundice, and we call it in this case icterus gravis. Now the fetus is going to compensate for the anemia by producing large numbers of immature erythrocytes to replace those hemolyzed in a condition called erythroblastosis fetalis. Okay. Hydrops fetalis is a severe form of erythroblastosis fetalis. Okay. The maternal antibodies attach directly to the Rh site on the fetal red blood cells, making them susceptible to destruction, resulting in severe anemia and multi-organ system failure. So here we go. Those characteristics are marked anemia, cardiac decompensation, cardiomegaly, hepatosplenomegaly, and hypoxia. Okay, so what can we do to intervene? There's two primary interventions that will help the fetus whose blood cells are being destroyed by maternal antibodies. First one is going to be early birth, as long as our baby is mature and will tolerate it, but also an intrauterine transfusion. Okay, so again, ideally that birth should be delayed until your baby has some kind of lung maturity. So that's confirmed around 36 to 37 weeks. Okay, so let's talk a little bit about some bilirubin. Bilirubin is a byproduct of red blood cell destruction. Okay, so as those red blood cells break down, then bilirubin is formed. The total bilirubin is the sum of what's called conjugated and unconjugated bilirubin. All right. Unconjugated bilirubin is indirect. It's considered fat soluble and it's not able to be excreted, so it can potentially be a toxin to our baby. The conjugated bilirubin in utero is passed through the placenta, and at birth the newborn liver must conjugate it or change it or metabolize it in order to excrete it. All right, so how do we end up with increased amounts of bilirubin? Well, bilirubin can be created when we have forceps or vacuum extraction deliveries because they can cause bruising, which we know is from the red blood cell breakdown. Okay. We can also have an increased blood volume from delayed cord clamping. So in other words, delayed cord clamping, when the baby is born, instead of immediately putting the clamp on, they'll actually leave it until the cord looks like it's drained of blood. They let the blood finish going to baby, and they wait until there's no pulsation, and then they clamp the cord. So what this does is this is increasing the amount of blood that is actually given to our baby. So with more blood leads to more red blood cell breakdown, leading to an increased bilirubin. Impaired conjugation of bilirubin, or metabolizing our bilirubin. Okay? If your newborn doesn't ingest adequate calories, then there's less hepatic binding proteins made, which gives us those higher bilirubin levels. Sometimes there can be a defect in bilirubin excretion because of a decreased GI motility and also a decreased oxygen to the liver. Okay, so let's talk about the normal conjugation of bilirubin. All right, so your unconjugated bilirubin binds to albumin and it travels via the blood to the liver. Okay, your liver is the site of conjugation. It has to get there. All right, so there's this enzyme, UDPGT. It helps the unconjugated bilirubin attach to glucuronic acid to produce conjugated bilirubin. Okay, once we're in the liver and we conjugate, the conjugated bilirubin is excreted into the bile ducts, the common duct, and then through the duodenum for excretion. In your intestines, the bilirubin is transformed into something called urobilinogen and stercobilinogen. So what we can have excretion through urine, which is the urobilinogen, or stool, the stercobilinogen. What is jaundice? Well, jaundice is that yellowing discoloration of the skin and of the sclera of the eye that can develop when your bilirubin starts to deposit in the tissues. Okay. Usually before you even see jaundice in your baby, the serum level is already at 4 to 6 milligrams per deciliter. So how can I detect jaundice in my baby? Well, for some babies, it's really obvious, especially if they're fair-skinned and they have a yellowish color all over. Okay? But other ways to double check that it's really jaundice is to press the skin on the forehead or the nose. And if it blanches, if it turns white, then there's no jaundice. But if you have blanching that's yellow in color underneath, then you do have jaundice. In the darker skinned ethnicities, it is harder to test for jaundice. The skin discoloration typically doesn't work. So you can see jaundice best in the sclera of the eye. Okay. Now, the rate and amount of bilirubin conjugation depends on the rate of hemolysis, so how quickly are our red blood cells being broken down, the bilirubin load, the maturity of the liver, because we need the liver to conjugate, and the presence of albumin binding sites. So if our bilirubin binds to albumin to get to the liver, if we don't have enough binding sites, it can't travel its way there. Physiologic jaundice is a normal process that occurs after the first 24 hours of life. Okay, so physiologic, normal, after the first 24 hours. Okay, this is from the newborn shortened red blood cell lifespan, a slower uptake of bilirubin by the liver, a lack of intestinal bacteria, or poorly established hydration. Okay. Total bilirubin levels in your babies peak around 3 to 5 days if it is a term baby, and 5 to 7 days if it's a preterm baby. Okay. How do we prevent high jaundice level? Well, first we can maintain the newborn skin temperature at 97.8 or above. We can monitor the amount of stool and urine since that's how it's being excreted. And we need to make sure that we're encouraging those early feedings to help push that bilirubin through. Right, these are some of the tests that we use to assess for jaundice. So in the top left, you can see that that baby has a yellowish tone to its face. Underneath that, we're testing skin color. Notice that this is a darker skin ethnicity baby, and they're using the soles of the feet to look for that yellowish blanching. So that's a possibility as well. And then over to the right is what we call transcutaneous bilirubin testing. So we just hold the monitor to the skin and it can give us a level. Of course, you can always draw their blood and get a serum level as well. Okay, so transcutaneous bilirubin, that's the one with the machine I just showed you. It's a non-invasive test and it quantifies the amount of bilirubin pigment in the infant's skin. All right, we have what's called the Coombs test. The direct Coombs is done on the baby, and this test determines whether jaundice is due to an Rh or ABO incompatibility. Indirect Coombs done on mom can detect if mom has developed any Rh positive antibodies in her blood. All right. Rh incompatibility, if that is what the problem is, it will give a positive direct Coombs test. If your baby's jaundice is from ABO incompatibility, we'll see a positive indirect Coombs test. All right, as far as the treatment of jaundice, we have phototherapy. So this actually exposes the baby to a high intensity fluorescent light. It converts that unconjugated bilirubin to what's called photobilirubin, which allows it then to be excreted by the baby in the bile or urine or in stool. It does not alter underlying cause of the disease. Okay. In exchange transfusion, we'll actually look at a little bit later. but here is what it is laid out. We are literally removing the baby's blood and replacing it with donor blood. Okay, when we do this, we're removing that high bilirubin level. All right, super important that we know how to care for a baby under phototherapy. All right, first of all, as the nurse, it's your responsibility to make sure that your equipment is working. So we use what's called a photometer, and we hold it up to the light, and it'll give us a reading to tell us how strong our light is, okay, and if the equipment's working or not. We want to make sure that the newborn's eyes are covered at all times while we're under phototherapy. The phototherapy light can damage a newborn's eyes. Now, we can take them out from under the light for a little bit of time, and when we do that, we can remove their eye cover at least once a shift for eye care, but also to bond with the parents in, some small increments. We do need to frequently reposition our babies to prevent any kind of overheating or burning from the light. So that's approximately every 2 hours we'll turn them. No lotions, ointments, or oils. We don't want the skin to burn. We do want to expose as much skin as possible, keeping in mind to keep that genitalia covered though, because it is a sensitive area that, again, could burn, okay? But the light works through the skin, so your baby shouldn't have anything on but the diaper, okay? We're going to monitor our eyes and nose, and we're going to assess for dehydration. All right, so in our baby, skin turgor is not the greatest way to assess for dehydration, but you could check for poor skin turgor, depressed fontanelles, when their eyes look sunken in, if we have a decreased urine output, or even weight loss. All right, we want to monitor baby's temperature, make sure they're staying warm but not overheating. We are going to do some daily weights, and then we're going to draw bilirubin levels as ordered, okay? Now, make sure, and this seems like common sense, but make sure that if you're drawing a bilirubin in the lab tube, that the phototherapy light is off. Otherwise, it will give us an inaccurate measurement. All right. In some cases, our babies can go home on phototherapy. If that's the case, then we'll send them home with a phototherapy blanket that wraps around them. Let's see here. This would be considered, mild jaundice, and it's definitely optional. Not everybody goes home with it. If they do go home with it, though, teach the parents to record the infant's temperature, weight, eyes and nose, stools, and feedings. Of course, they need to know how to use the equipment as well. And here are some pictures of different phototherapy. So you can see in the top left, let's see, this baby's got 1, 2, 3, 4 phototherapy lights going here. To the right, that baby's under photo. That's a really good picture, seeing the eye covering that's put in place. That baby is also laying on a phototherapy blanket. You can see the hose to the right end. All right, different kind of light down in the bottom left. And then bottom right is an example of a phototherapy blanket that we would send them home with. Okay, now on to jaundice and hyperbilirubinemia. Okay, make sure you review the basics from your prior course. All right, so physiologic jaundice is the one that occurs after 24 hours of age and is very common. Okay, that's the one you should have studied. We're going to talk about pathologic jaundice. So, pathologic occurs before 24 hours of life. Okay. It's usually a result from the Rh sensitization. It could be infection or severe trauma. Okay, so remember, Bilirubin is produced when your red blood cells are broken down, and it's called indirect or unconjugated. Must be transported to the liver for metabolism, which also refers to your conjugation. Okay, so what makes it pathologic? Okay, so this is basically some of the characteristics that tell you it's pathologic jaundice. Okay, so serum bilirubin concentrations of greater than 5 in cord blood, clinical jaundice event, which means we see jaundice before 24 hours, total serum bilirubin levels increase by more than 5 in 24 hours, or increase at a rate of 0.5. A serum bilirubin level in a term newborn that exceeds 12.9 at any time. In a preterm newborn, that serum bili that exceeds 15 at any time. Or in any case of visible jaundice that persists for more than 14 days of life in your term baby. All right, so why do I care about bilirubin levels? Well, unconjugated bilirubin can diffuse across the cell membranes and deposit in the skin and the brain. Okay, so remember, unconjugated bilirubins or indirect bilirubin can cross that blood-brain barrier. That's what we're worried about. Once it crosses, you can have two different conditions. You can have kernicterus, which is a chronic and permanent result of bilirubin toxicity, or you could have acute bilirubin encephalopathy, okay, which describes the acute central nervous system manifestations that are seen in the first weeks after birth. All right, so in looking at kernicterus, again, this is severe jaundice in the newborn where the bilirubin has crossed the blood-brain barrier and deposited in that basal ganglia of the brain. Okay, irreversible damage that includes cerebral palsy, mental retardation, hearing loss or a perceptual impairment, delayed speech development, hyperactivity, muscle incoordination, learning difficulties, and it can cause death. All right, acute bilirubin encephalopathy. Bilirubin deposits in the brain, producing cerebral damage and death. It can develop in newborns who show no apparent signs of jaundice. Okay, occurs during the first weeks after birth, associated with acute and long-term symptoms of neurological damage. These babies present with lethargy, hypotonia, irritability, seizures, coma, and they can die. Okay, so this picture is showing you a baby with advanced bilirubin encephalopathy. So you note in pictures A and B that the baby is very anxious looking. There's paralysis of the upward gaze with lid retraction and facial dystonia. In picture C, there's a bicycling windmill movement of the upper limbs. And in D, neck retraction and what we call scissoring of the lower limbs. Okay, so treatment for jaundice, make sure you review your phototherapy, as that is the #1 treatment, even in pathologic jaundice. However, it is possible to see an exchange transfusion. All right, so we're literally withdrawing and replacing the neonate's blood. All right, so these pictures kind of show you how it's being done here. We're going to use type O Rh negative red blood cells to treat both anemia and acidosis, but it also removes that bilirubin, maternal antibodies, and fetal red blood cells that are beginning to hemolyze. Okay, so literally what it looks like. You see on one side you've got donor blood, and on the other side is the waste blood from the baby. So you have two doctors, there's one on each side, and they're using the pull-push method to take a little bit out of the baby, push a little in, take a little out, push a little in, okay, until we transfuse that whole container of blood. Okay, so if my baby still has their umbilical lines, you know, we have an artery and a vein still, we can do it that way. Or if their umbilical line is already gone, then we can do it in just, you know, whatever normal veins we get. Okay, one is going to be preductal and one is going to be postductal. Okay, hence why you have two different sides.